convidar o Dr. Richard Santin para compartilhar a tela. E com a palavra, o Dr. Santin.
Christiane, I'm having problems.
To share the screen?
I had to change my internet.
Okay. So do you see those icons that we were checking before?
Yeah. Okay, now I think I'm okay now.
Yeah, I can see your screen.
Okay. So, and you can see the talk now?
Yeah, I can see the talk. You just put on presentation mode.
Okay, there we go.
Yeah.
All right. So shall I start?
Yeah, I've already introduced you, and I tried to say as much as I could about you, but of course it's difficult to say. Desculpa, eu tô falando em inglês. É difícil falar em tão pouco tempo sobre uma pessoa que teve tanto conhecimento, que desenvolveu tantas coisas para a nossa sociedade, e que, além disso, eu sei que é uma pessoa maravilhosa pelo pouco tempo que nós conversamos aqui, por tudo que os amigos falam do senhor. Então, para nós é uma honra tê-lo aqui conosco, e nós estamos com muita vontade de ouvir a sua fala.
All right, well, I'm very pleased to be able to speak to you in Brazil. I think the new technology has enabled us to share knowledge with our colleagues across the globe now, and this is something which is at least a positive aspect of the pandemic that we have. I'm going to talk today about the approach to the menopausal patient. And of course, the background for this is that the large randomized Women's Health Initiative trial precipitated quite a lot of controversy about the harms versus benefits of menopausal hormonal therapy. So several years ago, in response, the Endocrine Society commissioned in the US, commissioned a scientific statement to evaluate all objective evidence on this topic. And there were a group of 34 experts that wrote this scientific statement. And then since that time, a group of us, Ann Gompel, and Marianne Lumsden, Susan Davis, Joanne Pinkerton, Cynthia Stunkel, and myself, have tried to write articles to apply the principles about hormone therapy to patients. And so we've written 4 different publications now, and another one on premature ovarian insufficiency is soon to come out. So I'll incorporate the concepts developed during this collaboration in the discussion of the approach to a menopausal patient. And here you'll see some new concepts, perhaps, about using underlying risk of breast cancer in talking to your patients. Let's talk about a specific patient for background. So this is a 51-year-old white woman whose last menstrual period was 1 year ago. She has hot flashes that awaken her at night. They're associated with daytime fatigue and difficulties at work. Her second cousin died of breast cancer. She has a normal physical exam and laboratory data. Her bone density is normal, and her mammogram was normal, and the density was read as average, BRADS B. Now, I think the most important take-home message from the Women's Health Initiative study is that women make a decision about menopausal hormonal therapy shortly after menopause, and the risk-benefit data need to be tailored to such women. And of course, the Women's Health Initiative study, the average age was 60, and doesn't really apply specifically to women who are deciding whether or not to take hormone therapy. So in the discussion with our patient, she found her hot flashes very bothersome, and she would like some type of treatment. She was willing to consider menopausal hormonal therapy, but she was quite concerned about the risks of breast cancer, particularly because her second cousin died of breast cancer. She had read in the newspaper that breast density can influence breast cancer risk, but she didn't really understand why that would be or what normal breast density actually means. Another important principle is that each patient is different. We need to think about personalized medicine when we talk to patients about using personalized or using hormone therapy. And so we've stated in the guidelines that treatment selected should be tailored to the individual patient. And secondly, a fully informed woman should be empowered to make a decision. So what are the principles of personalized medicine that we need to think about? Well, each woman has a unique set of underlying factors that influence the harms and benefits of treatment in the process of making a decision. And there are a number of factors involved: blood pressure, body mass index, lipid profile, alcohol intake, and so on, and family history of breast cancer, heart disease, and so on. And in order to know about an individual patient, we somehow have to integrate these factors so that we can use all of these integrated for application of personalized medicine. So how do you integrate the factors? Well, we're all used to using the FRAX score to calculate the risk of fracture and osteoporosis. So for breast cancer, we suggest the IBIS risk evaluation method. This is the place that it can be found online. For cardiovascular disease, we suggest the American College of Cardiology, American Heart Association pooled cohort equation. And this is the site where that can be found. So let's talk about our patient. The first thing we have to talk about making a diagnosis. So the criteria in at least published literature for a diagnosis of menopause: at least 1 year after the last menses, total abdominal hysterectomy and bilateral salpingo-oophorectomy, or total abdominal hysterectomy, but the ovaries are preserved and the patient's over age 55, or total abdominal hysterectomy and the ovaries are preserved, and then serial LH and FSH and estradiol less than 10 with sensitive and specific assays. And we say serial because these can vary, and you need several to be sure that the patient has actually gone through the menopause. We then talk about step 2, which is health considerations for all men, all women. And we consider only women less than age 60 or less than 10 years since the menopause or late perimenopausal are really candidates for hormone therapy in the menopause. So what do we need to think about? We need to think about bone health, smoking cessation, alcohol use minimization, cardiovascular risk assessment and management, and cancer screening and prevention. It's interesting that most published literature say that we shouldn't try to prevent disease with menopausal hormonal therapy, but there's an exception. And that is that women without vasomotor symptoms and at significant risk of osteoporosis can discuss the merits of menopausal hormonal therapy for bone preservation, even though they don't have any symptoms related to the menopause. So if a woman does have vasomotor symptoms and they're moderate or severe, and the patient has interest in menopausal hormonal therapy and no contraindications, then we might go down this third step. So what are the contraindications? I have to say we had a lot of trouble finding specific contraindications in the literature. And so what we did was to use the list of contraindications which were written by the Food and Drug Administration in the United States for guidance of physicians. And these are obvious: undiagnosed abnormal genital bleeding, known, suspected, or history of breast cancer, other estrogen-dependent neoplasia, active DVT, deep venous thrombosis or pulmonary embolism, active arterial disease, anaphylactic reactions, and then some rarer things. But one always has to suspect pregnancy. Relative contraindications are that estrogen does increase gallbladder disease. It markedly increases triglyceride in a subset of patients. I don't think diabetes really is a contraindication. Hypoparathyroidism, because estrogen can lower calcium. benign meningioma, and some patients with migraine with aura. So when the Endocrine Society in the US was trying to set up these clinical guidelines, we wanted to have the best data possible about whether transdermal therapy might be associated with a reduced risk of venothrombotic episodes when compared with oral estrogen therapies. And the reason for this is that there is a tendency now to prefer transdermal estrogen. So the Endocrine Society did a systemic review, and what we saw was that the risk ratio of oral estrogen versus transdermal estrogen, the hazard ratio was 1.63, statistically significant, that oral estrogen had a higher risk of VTE than did transdermal. This was true for deep venous thromboses as well. And our conclusion was that low quality evidence, because there were only observational studies, suggests that compared to transdermal estrogen, oral estrogen therapy may be associated with an increased risk of venous thrombotic episodes, deep venous thromboses, possibly stroke, but not myocardial infarction. What we didn't look at is whether transdermal estrogen has any increased risk of VTE. There was a very large observational study by Dr. Canonico, 80,000 postmenopausal women in Europe, and they compared never use of transdermal estrogen with current use. And this signal suggests that transdermal doesn't cause DVT or venous thrombotic episodes. We tend to think then that oral estrogen goes to the liver, and its first pass effect on the liver is to stimulating clotting factors. And that doesn't appear to happen with transdermal estrogen. So the next thing that we need to think about in patients is an analysis of benefits versus risk. And this can really only be done practically by looking at the usual time to decide on menopausal hormonal therapy shortly after menopause. And we've considered the risks and benefits for those only 50 to 59 years of age or less than 10 years after menopause onset. And we would assume that most women take menopausal hormonal therapy for about 5 years. So we've expressed risks and benefits as attributable, the excess risk when comparing users with non-users over a 5-year period. And to do this, we use the Women's Health Initiative post hoc analysis based on age of the patients. Complicated slide, but let's go over it. So if we look at CEE during the intervention phase, and this is the number of women per 1,000 per 5 years of use with an excess risk, you can see that about 2 women with conjugated equine estrogen MBA have an increased risk of coronary heart disease and invasive breast cancer. It's actually not very high, it's 2 out of 1,000. Increase in stroke, pulmonary embolism, and deep venous thromboses as secondary endpoints. A marked reduction in fracture, and actually a reduction or an improvement of all-cause mortality as well. And then as a self-reported endpoint, an improvement of diabetes. Let's look then at conjugated estrogen alone. And here, about 5 women have a reduction of coronary heart disease, 5 women out of 1,000 using it for 5 years, a reduction in invasive breast cancer, still an increase in pulmonary embolism and deep venous thromboses because these are oral estrogens, a reduction in all fractures, a reduction in all-cause mortality, and a marked reduction in self-reported diabetes as an endpoint. So that you can see the risks are not very substantial, the benefits occur, and one needs to balance the risks and benefits. Now I'm going to introduce what I think is a concept that really has been underemphasized in the literature. And that is, does the underlying risk of breast cancer influence the risk of developing breast cancer with menopausal hormonal therapy? So all previous data from randomized controlled trials or even observational studies have examined the risk of breast cancer, but have neglected to look at the underlying risk. And we believe that these data likely overemphasize the risk in women who are at low risk of breast cancer and underemphasize the risk in those that are at high underlying risk. So how do we conclude this? So we developed two models which integrated several elements of tumor biology and population epidemiology. In the model, the average doubling time of a breast cancer was 200 days. 7% of women ages 40 to 80 who are started on menopausal hormonal therapy already have breast cancer, as detected in autopsy, but is not large enough to be seen, too small to be detected clinically. And the size threshold for detection of breast cancers is about 1.16 centimeters. How do we calculate the doubling time of a tumor? It's done by looking at serial mammograms in patients. And you can see that there's a peak doubling time at about 100 days, but the median is 200 days. And some patients have doubling times as long as 800 days. And this may be the group of women that are now said to be overdiagnosed when they have breast cancer and it doesn't seem to progress later. I won't go over this in detail, but these are the 7 autopsy studies looking at the incidence or the prevalence of breast cancer in autopsies. And these were women 40 to 80 dying of something else. In situ breast cancer, 6%, invasive 1%, and total 7%. So a lot of women are walking around already having breast cancer. And we calculate that it takes about 20 years to go from one cancer cell to 30 doublings, enough to detect it on mammogram or on clinical examination. So is our model valid? We compared it with the large population-based SEER data in the United States versus our model, and you can see it predicts it quite well. When we look at the population incidence with several studies, SEER, the Women's Health Initiative placebo studies, and so on, the expected, according to the model, is green, and you can see it tracks quite well. It also tracks contralateral breast cancer. So we feel that this model can tell us something about our patients. So the modeling data suggests that it takes on average 20 years, this is the average, for a new breast cancer to double 30 times so that it is large enough to be seen on a mammogram or become palpable. 7% of women already have occult breast cancer, and menopausal hormonal therapy, we believe, really doesn't cause breast cancer. It just promotes the growth of these occult lesions that are already there. And our model would say that of the women who develop breast cancer with menopausal hormonal therapy, after 8 years, only a very small 6% are de novo tumors occurring and growing very rapidly, whereas the majority were tumors that were already there and were just altered by the menopausal hormonal therapy at the time that you started treatment. So when we looked at this, if the average tumor has a doubling time of 200 days, and you give the patient estrogen and progesterone, and the doubling time increases to 150 days, this tracks very well with the observed WHI data. So we would conclude from this that's what's happening when we give our patients estrogen and progesterone. You're just increasing the growth time in tumors that are already there. So how does one calculate the underlying risk of breast cancer? We like to use this, the IBIS model, and you can do it in your office on your computer. It looks at a woman's age, her first child, whether there's breast cancer in the family. It prints it out, and you can see this particular patient at age 85 has a 26% risk of having breast cancer versus the population. and the risk after 10 years is 6.8%. Now, the interesting thing is, if you would plug in our patient's secondary degree relative, the cousin with breast cancer, that actually doesn't increase her risk of breast cancer at all. I would recommend that this is a good tool to use, and again, very analysis to a FRAX assessment of fracture risk. So we've published then that the assessment of underlying risk estimates change the likelihood that the patient already has an occult underlying breast cancer. So if her risk is high, she probably has an increased risk of having an occult breast cancer at that time. Now, what are the data that suggest that the underlying risk of breast cancer is useful? And not everybody agrees with this. This is a new concept. So if you look at the predicted risk of breast cancer and the effect of menopausal hormonal therapy at 5 years, based on the underlying risk of breast cancer. So using the Gale model, if a woman has less than a 1.25% chance of developing breast cancer at 5 years, her relative risk with hormone therapy is 1.9. If her risk is 1.25 to 1.75, her risk is 1.2. And if her risk is greater than 1.75, her risk is 1.25. So there's no change in relative risk based on the underlying risk. People have missed the fact that even though the relative risk is the same across underlying risk categories, as the absolute risk increases, the excess risk attributable to MHT increases concomitantly. So the relative risk doesn't change, but because the underlying risk is higher, the excess risk that occurs when you're on hormone therapy goes up. So in our JCNM publication, what we've shown here is that if the 5-year risk of breast cancer is 1.5%, this is the increased risk of breast cancer with estrogen alone. It's about 20. If the underlying risk at 5 years is 3%, this goes up to 40. And if our underlying risk is 6%, this goes up to about 80. And this is even more exaggerated with estrogen plus a progestogen. Actually, our patients are a lot smarter than people writing the articles because they know that if they have a family history of breast cancer, they're at more risk of taking hormone therapy. But it's quite clear that the underlying risk is important, and we need to talk to our patients about that. So just to comment on this, the statistical means of validating the role of underlying risk on attributable risk is complex, and it was really ignored until recently. But as I say, women know about this. And so we've really come down with a strong recommendation that we need to talk to patients about their underlying risk of breast cancer. So the Endocrine Society guidelines have used this as a key component in decision making. So if the breast cancer risk at 5 years is low, less than 1.67%, menopause hormonal therapy is okay. If the risk is intermediate, 1.67 to 5%, one should use caution. And if the risk is high, greater than 5%, this would be a contraindication to using hormonal therapy. So the next component is evaluating cardiovascular risk. If it's high, you need to consider other options. If it's acceptable, what we want to do now is to calculate the underlying risk of cardiovascular disease. And that can be done with the risk evaluation method that I showed you earlier. We can then put this into guidelines originally developed by Joanne Manson. So if the 10-year risk of cardiovascular disease is low, less than 5%, menopausal hormonal therapy is okay. Using it for 5 years, it's okay for using it for 6 to 10 years. If the risk is moderate, 5 to 10%, using it for 5 years, menopausal hormonal therapy is okay, but you might choose transdermal. And for 6 to 10 years, probably still okay, and choose transdermal. But if the risk is high, greater than 10% at 10 years, you want to avoid menopausal hormonal therapy. So this suggests that when we're talking to patients about using hormone therapy, we need to calculate their risk of breast cancer and their risk of cardiovascular disease. I won't spend much time on this because we all know that with systemic estrogen therapy, we can either use oral, transdermal, or vaginal. Vaginal is not associated with an increased risk of breast cancer. We can use estrogen with a synthetic progestogen combination using oral estrogens or transdermal estrogens. We can use systemic progestogen therapy, an oral synthetic, a bioidentical, and this would be oral micronized progesterone. My colleagues like this because it might be associated with a reduced risk of breast cancer. And we like the Mirena, the intrauterine levonorgestrel, because the amount of progestogen in the systemic circulation is quite low. Other agents, of course, are conjugated equine estrogen plus beta-doxyphene. We call this a tissue-selective estrogen complex, or tibolone. And it's interesting that tibolone is approved in 37 countries, but not in the US. So we don't have any experience with that. Let's talk a little bit about this new therapeutic approach. It sounds paradoxical, and this is the tissue-selective estrogen complex. The only one available, it's a conjugated equine estrogen, Premarin, plus beta-doxyphene, the selective estrogen receptor modulator. Even though you're giving an estrogen and an anti-estrogen together, it has a unique cDNA array signature. It causes effective relief of symptoms. It eliminates the need for a progestogen, and it's approved in the USA and the European Union, not in Australia, and I don't know if it's approved in Australia, in Brazil. You'll have to tell me that. I call this the endocrinologist menopausal hormonal therapy because these patients don't bleed, and you don't need a gynecologist to usually to deal with the unplanned bleeding issues. So what are some of the controversies that we have in the treatment of menopausal symptoms? So we're still discussing what are the best methods to assess cardiovascular disease and breast cancer risk prior to starting menopausal hormonal therapy. I've suggested the two that most people would agree on, the IBIS-1 and the American Heart Association. Are some MHT preparations, doses or routes of administration safer than others? Well, the French have done a very large study suggesting that progesterone and dydrogesterone are safer in the sense that they don't have as high risk of breast cancer. That's not validated in randomized controlled trials, but I myself prefer to use micronized progesterone, prometrium, as the progestogen. What duration of menopausal hormonal therapy is safe? You could see from the slide that I showed you that the risk goes up over time. So the concept of using it for the shortest period of time is probably, for most patients, a reasonably good principle. What are the effects of MHT on prevention? Well, there is a decrease in mortality. There's a decrease in fractures. But in general, most people would only suggest a preventative effect to reduce the risk of fractures in a patient with known osteoporosis. And of course, we don't have compelling data on mortality, but the data that's out there suggests that menopausal hormonal therapy, if started early, may in fact be associated with a reduction in mortality. So there's one caveat. We all have patients that might be at increased risk of cardiovascular disease or might be at increased risk of breast cancer, but they are miserable. And you can only benefit them with their symptoms by putting them on hormone therapy. So one of our guidelines says, as the impact of severe menopausal symptoms on quality of life may be substantial, there are instances in which a woman of coronary heart disease or breast cancer might choose to accept the risk that might be considered to outweigh the benefits. So we've come up with the philosophy that if a woman knows exactly what her risks are, she's fully informed, she should be empowered to make a decision that best balances benefits to that individual with weighed against potential risks. So the way I do that, if somebody is at higher risk for breast cancer or for heart disease, I tell them what their risks are. And if they still want to have hormonal therapy, I just write in the chart that I've explained this to them and that they sign what I've written so that they know and I know that they've been fully informed. And I have a lot of patients that I have on hormonal therapy who benefit by relief of symptoms using this methodology. So what did we do in our patient? Well, she has severe hot flashes. We calculated her risk of breast cancer and cardiovascular disease, and they were low. We explained to her that a second cousin with breast cancer doesn't increase her risk. I'd like to have the computer up in my office and use the IBIS method to show them what actually does increase risk. And they can see from that that their cousin that they have actually doesn't increase their risk. Our patient had no contraindications, and she decided to use cyclic transdermal estrogen and oral progesterone, prometrium, for 2 years, and then reconsider. So this individual is going to still have bleeding, but if we put her on continuous combined therapy, she's going to have unexplained bleeding. So we generally use this for 1 to 2 years. The other option in this patient would be to put her on the TSEC, Duavi or Duaviv, the conjugated equine estrogen plus beta-doxyphene. And then further decisions about continuing will really depend on ongoing annual assessment and discussion of benefits and risks. So this patient is done very nicely. It takes time to go over all of this with the patients, and that's a problem. But I think in the milieu of this, the patient needs to understand and be fully informed, and we have to take the time to do this. Now, this particular patient had an interest in taking menopausal hormonal therapy. If she had severe vasomotor symptoms and did not want to take menopausal hormonal therapy, any of these agents, paroxetine, venlafaxine, the SSRI or SNRI, will reduce the severity and the frequency of hot flashes shown here in blue, not to a greater extent more than placebo, but patients actually don't care if they're responding to a placebo or to the medication. The bottom line is that their symptoms are improved. And so we recommend this for individuals that don't want to have menopausal hormonal therapy. And then the final thing is, what if a patient just has vaginal symptoms? GMS, the genitourinary syndrome of menopause, a new term. It's becoming more popular. Of course, the symptoms involve our pain, urinary tract infections, dysuria. You know all of the symptoms, and you know pretty much the signs, and you know the vaginal signs. We won't go over all of these, but these patients can be treated with vaginal estrogen, and we prefer low-dose vaginal estrogen as opposed to systemic estrogen if the vulvovaginal atrophy is the only indication. Why do we use low doses? And this would be Vagifem 10 micrograms. Now in the US, there's a 4 microgram dose. The lower the dose of vaginal estrogen, the lower systemic estrogen levels that result. And it's been shown that vaginal estrogen really is safe, doesn't increase the risk of breast cancer, doesn't increase the risk of heart disease. So with that, I want to thank you very much for your attention, and I wanted to leave a substantial amount of time because many of these things are controversial.
Muito obrigada, Dr. Santen, pela excelente aula. Nós já recebemos aqui, é sempre muito esclarecedor ouvi-lo falando, e nós já recebemos aqui inúmeros comentários, inúmeras perguntas também. Né? Acho que nós podemos passar aqui a uma sessão de perguntas, né? Para termos um bom debate assim, a respeito desse assunto, que é sempre tão interessante tanto para os ginecologistas quanto para os endocrinologistas. Então, vou começar aqui fazendo uma pergunta da doutora Ruth Klapaut. Ela parabeniza pelo evento, e ela tem aqui duas perguntas. Primeiro, se há diferença entre as vias de reposição oral e transdérmica e a incidência de câncer de mama. É a primeira pergunta dela. E uma outra pergunta é sobre o risco do câncer de mama em mulheres obesas versus magras submetidas à terapia de reposição hormonal.
Christiana, I'm only hearing the Portuguese, unfortunately.
Oh, can you go and change to in that icon? You can change to English? No? Do you see that globe, that small globe beside question and answers?
I can't see it now.
Oh, okay.
Let me try to take the slides down.
If you can see the question and answers, she typed, Dr. Ruth, she typed in English.
Yeah, so let's, I know, Ruth, thank you very much for your question. We meet in the US frequently. The question is, are there differences between estrogen routes, oral and transdermal, and breast cancer incidence? Christiana, was that translated into Portuguese?
Can you repeat? Sim.
Yeah, yes. So when I talk, is this translated into Portuguese?
Yes, it is.
Okay, all right. So the Women's Health Initiative study did not give us any differences between the estrogen routes and breast cancer incidence. The most recent collaborative study in the Lancet in 2019, which was a pooling of 58 different studies in multiple countries, has looked at this quite carefully. And there appears to be no difference between transdermal estrogen and oral estrogen on breast cancer incidence. And there appears to be no difference between conjugated equine estrogen and estradiol itself. The only difference that they saw in terms of route was that there was no increased risk of breast cancer with vaginal administration of estrogen. Now, this is a difficult question because in the Women's Health Initiative study with conjugated equine estrogen, there appeared to be a decreased risk of breast cancer in women that started this more than 5 years after the menopause. And all of the other studies not using conjugated equine estrogen seem to show an increase. So it's raised the question whether there's a difference between conjugated equine estrogen and estradiol. Dr. Wei, you and myself have published an article in Animals showing that conjugated equine estrogen causes very much less stimulation of existing breast cancer than does estradiol. But I have to say that in the collaborative study, the large collaborative study, and most all other studies, there seems to be no difference between conjugated equine estrogen and estradiol. So I hope I've answered that question.
Dr. Santen, if you stop sharing your screen, you're gonna see the icon for simultaneous translation.
Okay.
On the top.
Yeah, I'm trying to do that if I can.
Over the ask keyboard.
Okay, you're right. I got it. Okay, now I can.
All right. Okay. Now you can see English and Portuguese.
Yes, now I can hear the English. Thank you.
Okay, wonderful.
Ok, great. So, passar só mais uma pergunta da doutora Ruth, ainda continuando no que ela perguntou nesse assunto, e aí eu vou passar para o Vinícius fazer a próxima pergunta. A doutora Ruth pergunta sobre o risco de câncer de mama em mulheres obesas versus magras, submetidas à reposição hormonal.
All right, this is an excellent question. So in the collaborative study, which has the best data, the increased incidence of breast cancer is much less in obese patients than it is in thin patients. This is particularly true for estrogen itself. Now, the underlying thought about why that's the case, we know that aromatase activity, the enzyme that converts androgens to estrogens, goes up linearly with obesity. So if you weigh only 50 kilograms as a woman, about 0.5% of testosterone is converted to estrogen. If you weigh 150 kilograms, almost 10% of androgen is converted to estrogen. And we know then that in postmenopausal women, obese women have higher levels of estrogen than do thin women. And that's the reason, increased aromatase. So if you already have an increased risk, if you already have an increased level of estrogen in the blood, and then you give estrogen in addition, some of the effect of estrogen has already been seen because the patient is obese. So that explains why the risk of breast cancer is much less with menopausal hormonal therapy in obese women versus thin women. This is very clearly shown in the collaborative study. And for those of you that have the time to read it, the supplementary material that has 30 different figures and tables is the way you find this information. But it's quite clear that obesity is very important.
Ótimo, obrigada, doutor Santen.
Eu vou fazer a pergunta agora, passar a pergunta da Réia Pinheiro, nossa colega, ela pergunta se é possível fazer a terapia hormonal com estradiol e progesterona, variando as doses do estradiol ao longo do ciclo, mimetizando ainda um ciclo menstrual normal. Existiriam vantagens nesse tipo de esquema?
There have been no data to suggest that might be beneficial. There's no data at all. It's interesting, however, that if you look at the risk of breast cancer in women and correlate that with the level of estradiol in the plasma, there's a very clear relationship. The higher the plasma estradiol, the greater the risk of breast cancer. That's within the postmenopausal normal range of 2 to 10. So theoretically, if one altered the amount of estrogen during the month, that might have a different effect on breast cancer. I don't think we'll ever have the studies to know that. And of course, in this situation, you don't want women to bleed. So I think there's potentially one might think about that in that situation, but there are no data that I'm aware of that has looked at that approach.
Uma outra pergunta dela também, ela pergunta aqui, vou fazer essa pergunta que eu tenho interesse, porque eu trabalho com reprodução assistida, né? Então, essa pergunta dela, ela diz se mulheres com 44 anos, com ciclos irregulares, fogachos, porém com poucos folículos, ela pode iniciar a reposição hormonal. E iniciando essa reposição hormonal, ela poderia ainda tentar uma estimulação para a ovodoação.
So here we're really talking about this POI, premature ovarian insufficiency. And this is an analogous situation to what the question is about, because these are women that have some estrogen in some cycles and not much estrogen in other cycles. And the data on premature ovarian insufficiency would suggest that those women do benefit by giving them estrogen. Now, in the 44-year-old with the irregular cycles and so on that's talked about, if that woman have severe hot flashes or other issues, certainly one could give estrogens under those circumstances. In terms of the preservation of the ability to induce ovulation, I'm not aware of any good data to answer that question. There have been data suggesting that women with premature ovarian insufficiency, if you give them estrogen, might have an increased ability to achieve pregnancy or ovulate. But those data have been very controversial and never really proven. So I think that's an open question, whether estrogen in that situation might be beneficial in terms of later reproductive health or not.
Certo. Doutor Santen, outras pessoas têm perguntado também sobre o uso, uma pessoa perguntou sobre o conceito do basedoxifeno, para explicar um pouquinho melhor, que não entendeu muito bem qual é o conceito, porque nós não temos aqui no Brasil, pelo menos não é comercializado, e também juntando nessa mesma pergunta, se ele pode ser utilizado em pacientes com risco de trombose.
It cannot be used. Well, the combination of conjugated equine estrogen and basedoxifene cannot be used in a patient with deep venous thromboses. Basedoxifene alone can. Now, the concept, the way I like to think about it, is that the estrogen receptor with estrogen bound to the receptor is a dimer. And if estradiol is on that receptor, you have 1 degree of change in configuration of the receptor. If on one side of the receptor you have conjugated equine estrogen, and on the other side you have basedoxifene, you have yet again another alteration in the configuration of the receptor. What that results in then, if you look at a cDNA array in terms of what genes are turned on by estrogen or by the combination of CEE plus basedoxifene, the pattern is totally different. So you have multiple genes that are regulated differently when you have the combination than when you have estrogen alone. Now, to me, the advantage is that if you give the TSEC, basedoxifene and conjugated equine estrogen, to a 50-year-old woman, her bleeding pattern is the same as a woman that's not on estrogen alone. In other words, markedly reduced compared to putting a patient on a combination combined non-cyclic estrogen plus a progestogen. And so that's one of the major advantages. The other issue, and it's under study now, since you're giving basedoxifene, which prevents breast cancer, with conjugated equine estrogen, is it possible that this will not have an increased breast cancer signal over time? The only thing we have now is a 2-year study of biomarkers, which suggests this might be the case, mammary density, which doesn't go up with the combination, but we need to have long-term data to see about whether the combination is not associated with an increase in breast cancer. Our data, preclinical data, using nude mice tumors and so on, shows that the combination actually doesn't stimulate these existing breast cancers. So this is an interesting area, but for right now, I think the major advantage is the lack of bleeding.
Muito interessante o mecanismo, muito interessante essa questão da assinatura gênica. Realmente muito legal isso, muito bom. Você quer fazer a próxima pergunta, Vinícius?
Bom, a Fernanda Salles, ela está perguntando a respeito da terapia hormonal em mulheres com mutação do BRCA após a oforectomia. Né? Alguma consideração a respeito desse assunto, professor?
I missed the after oophorectomy for what indication?
Ela uma paciente que tem a mutação do BRCA e ela foi submetida à oforectomia, né? Então, a respeito disso, como seria a terapia hormonal?
BRCA mutation.
No, that's a good question. Yes, no, right. So the individuals that study BRCA in women after the childbearing period that have had a oophorectomy, they believe that estrogen or menopausal hormonal therapy is safe in that situation up to the time of usual menopause. And probably that's the case in that what you're doing really is replacing a degree of estrogen that would have been there if the patient had ovaries beforehand. And these women are younger and don't have a very high incidence of breast cancer at that age anyway. So the guidelines for BRCA are that in these patients, they can take menopausal hormonal therapy.
Uma outra colega vem perguntando, a doutora Helena, se no caso de uma paciente que teve trombose pós-parto, ela teve que fazer esterectomia por complicações após o parto, se ela poderia fazer a terapia de reposição hormonal na menopausa.
Yeah, this is again an excellent question. I usually look at this in two ways. First of all, I want to know whether there's an underlying condition other than pregnancy that resulted in her having deep venous thrombosis. So factor V Leiden, prothrombinase defects, and so on. And if that's absent and the patient has not had further thrombotic episodes over time, I usually go to my hematologist clotting expert and ask them if they think there's any other increased risk, underlying risk at this point of DVT, and then I use transdermal estrogen. So I've done this in patients. We've had a lot of discussion about whether this is safe or not. And of course, the transdermal estrogen data that it doesn't cause DVT or pulmonary emboli are all observational, and it's mainly from the EPIC-3N study in Europe. But I think because transdermal doesn't have a first pass effect and the observational data suggests that it's safe, that's what I would use in this patient that had a problem with postpartum thrombosis. Now, I have to admit that I don't know a lot about the pathophysiology of postpartum thrombosis, and that's why I would usually go to my clotting expert to give me a little bit more information there. But in that circumstance, I think with transdermal, and if there's not a mutation, I think it's probably would be okay.
Mais alguma pergunta, Vinícius? Você queria fazer? Tem muitas perguntas, a gente está até com dificuldade aqui de selecionar, né, Vinícius? Pode ver mais.
Tem uma boa aqui. Paciente com reposição hormonal em dose padrão, que persiste com sintomas vasomotores. Qual seria o próximo passo para essa paciente?
Yeah, so the first step is to increase the estrogen dosage, and I'd like to measure estradiol levels in that situation. And of course, the question is, what is a normal estradiol level in a woman? And the way we think about this is that if you measure estradiol daily in a cycling woman, the average estradiol level is about 100 to 125 picograms per mil, 300 picomole per liter. And so I use transdermal estrogen and gradually increase the dose till I get up to about 100 to 125. Many of the patients will have a decrease in their vasomotor instability with those increases. If that doesn't work, I then ask the patient if they have trouble at night or during the daytime. Most people don't distinguish nighttime hot flashes from daytime, but it makes a huge difference. If you can't sleep and you're waking up at night, those individuals, I use gabapentin, and I use it in a dose that's given once at night, and I use a dose that is basically cleared by the next morning so they don't have side effects. Usually that helps. If they have daytime hot flashes, I will add an SSRI or an SNRI. There's something new though, which is interesting, and that is that the agent that's used for hyperactive bladder in postmenopausal patients works pretty well for hot flashes. So that's another agent that's been shown in randomized trials to work. I'm blocking on the name. It's getting close to dinner here, so but it's the major treatment of overactive bladder. I'll think about it in a minute. So that's my approach.
Obrigada. Temos ainda tempo para mais algumas perguntas. A doutora Amanda Taide pergunta, o estrogênio vaginal relacionado a pouco câncer de mama tem ação só vaginal ou algum efeito sistêmico? E, por exemplo, se teria um efeito sobre a proteção óssea e para a diminuição dos fogachos?
Yeah, yes, there's no effect on reducing hot flashes. However, if one uses the S-ring, which is a silastic ring that delivers 7.5 micrograms of estradiol into the vagina daily, which works, there is some reduction in bone resorption. So it would appear that the postmenopausal woman, the bone is very sensitive to low amounts of estrogen, but no breast cancer, no reduction of hot flashes, no DVT. But one has to be very careful because Premarin and estrase, 17-beta estradiol or conjugated equine estrogen, you can't get it in doses low enough to have strictly local effects. So 10 micrograms of 10 micrograms of estradiol with Vagifem, or in the US, there's a new one at 4 micrograms. It works quite effectively and doesn't seem to have systemic symptoms. But this issue of reduction of bone resorption is very interesting. We know that the Menostar, which is 14 micrograms of estradiol delivered systemically, that reduces bone breakdown also. But basically, if one's going to do this, we recommend very low dose estrogen so it doesn't increase systemic levels. And that's 4 to 10 micrograms of estradiol given twice a week.
Tem mais alguma pergunta, Vinícius?
Tem um aqui interessante, se existe ainda espaço para reposição via oral, sabendo das vantagens da via transdérmica, de menor riscos, qual seria então a indicação para utilizar então a via oral para reposição?
My opinion is no, but of course the world believes that oral estrogen is good. So, you know, if someone doesn't have a risk of DVT and so on, oral estrogen works reasonably well. In the US, sometimes the oral estrogen is very much less expensive, so that we have to use that. But my own preference is transdermal, based on what you say, and the Prometrium, which really is bioidentical hormone therapy, if you like that. So I think time is going on. As time goes on, there's more and more use of transdermal estrogen, looking at worldwide use. So I think your concept is right. It's going to take some time, basically, to get there. Do you agree with my opinion? Interesting.
Interessante. Acho que daria tempo para mais uma pergunta, ou quer finalizar, João? Fazer aqui só mais uma perguntinha sobre
a última pergunta. Nós temos 300 perguntas aqui. O Vinícius ou Cristiane escolhe uma e
a gente tenta ver o que engloba mais. Uma pergunta aqui falando sobre se a reposição hormonal pode reduzir o risco de câncer de intestino e, em caso positivo, qual o mecanismo?
Yes, it can. There is a reduction. There are estrogen receptors in the bowel, both estrogen receptor beta and estrogen receptor alpha. It's thought that probably it's ER beta that is protective. We wouldn't recommend treating a woman with hormone therapy just for that reason. But in the randomized trials from the WHI and the observational data, it clearly is a reduction. And it seems to be because there's estrogen receptors present, and particularly ER beta.
Uhum. Bom, então, com isso, nós não teremos tempo de finalizar todas as perguntas, mas acredito que nós tentamos englobar a maioria das perguntas. Realmente, todos adoraram a fala, muitas congratulações pela excelente palestra. E eu vou deixar, então, com o Dr. João Lindolfo para finalizar aqui com a gente. Agradeço, Vinícius, sua participação e a participação de todos os colegas ginecologistas, nossos colegas da endócrino. Realmente é uma oportunidade única de beber dessa fonte de sabedoria do Dr. Santen.
Obrigado, Cristina. Muito obrigado pelo convite. É claro que queremos fazer mais eventos como este, aí, nossas associações juntas, né?
Ótimo, vamos fazer.
Muito obrigado a todos. Obrigado, Dr. Santen. Obrigado, Cristiane e Vinícius, que conduziram isso muito bem. Muito obrigado aos 200 participantes que tivemos aqui. Dr. Santen, a próxima vez em Charlotte eu irei te visitar. E muito obrigado. E já deixo o convite para vocês para o nosso próximo Vitem, que vai ser o ano em vitamina D. Boa noite a todos.
Boa noite, muito obrigada.
Boa noite, obrigado pelo convite.